Okay, so for this last session, we're going to have some case presentations. So Manos and Subhash are not only prolific in their own research studies, but they've spawned a number of offspring in terms of fellows who come through the lab and training and fellows who perform research. And so we're going to have 3 of those fellows present cases. And in addition, we're going to have my non-interventional cardiology colleagues come on up. We have Shoaib Abdullah, Diane Cow, Nicole Minifield, and Samya Chandrasekaran. So why don't you guys come on up? And while they're getting comfortably seated, I want to also give a shout out to several of our adjunct non-invasive cardiologists who actually help us at the VA on a regular basis. So there's Don Levine, we have Stephen Johnson, Abraham Jacob, and Sachin Gupta, and they really do provide us with some additional clinical as well as educational benefit. The last thing I want to say before we get into the cases is, as in my position as CCU director, I have the great opportunity to get all of this teaching. Many of the lectures that you heard today are actually given as part of a formal didactic series to the residents. But it's all made possible with the wonderful contributions of my colleagues. And so this is actually a simulation of what often would happen. The fellows would collect all the data. I might be the attending saying, okay, what do we do? Let's go talk to somebody who knows what, has the best possible advice. And we have a collection of people here who are going to give us advice in these cases. So with that being said, we'll jump right into the first case. And Vijay, would you mind coming on up? Present?
Hi, my name is Vijay Raja. I'm one of the interventional fellows this year, and my first case is going to be about cardiac hemodynamics. I have nothing to disclose, just a quick comment that I wanted to make on behalf of the other fellows as well. All 3 of us have been very lucky to have completed all of our postgraduate training at UT Southwestern and at the VA Medical Center. And what you've experienced today and yesterday is pretty much what we consider to be lucky part of our training. This has been an excellent educational forum today and this weekend, and this has been our past 6 or 7 years. So we're very thankful for that. And it couldn't be possible without the program directors, the faculty and staff that are here, and also all of our nursing and allied health professionals that are with us today. So thank you. So with that, our first case is a 74-year-old gentleman who has a history of chronic obstructive lung disease, type 2 diabetes, hypertension, hyperlipidemia, and major depressive disorder, who's on current treatment. He presents with symptoms to his primary care doctor with dyspnea exertion at 50 yards. His exam at that time was notable for a barely audible S2, a late peaking systolic murmur at the right upper sternal border, and that's radiating towards carotids. So, rightly so, an echocardiogram was ordered for the patient. Sorry. So these first 2 images are from a parasternal view, so from the chest wall. The first view on the left is what we call a parasternal long axis, showing the LV as well, and then the parasternal short axis, showing preserved ejection fraction with a reduced excursion of the aortic valve leaflets. So this is what we call the apical view, so apical 4-chamber and apical 2-chamber. This is taken from basically where the point of the PMI would be normally felt, but showing also again normal wall motion. So this is a zoomed view of the aortic valve, again showing the reduced excursion of the leaflets, the aortic leaflets. And then, importantly, taking a measurement of the LVOT, giving us a diameter that's going to be used as part of our equation for the continuity equation to determine what the aortic valve area for the patient is. That determination is made by collecting continuous wave Doppler and different views, as well as pulse wave Dopplers of the LVOT. I know that the imaging is not great to see, but these are the two views from both the apical 5 chamber and apical 3 chamber. And our summary of details showed that the patient had preserved left ventricular systolic function, a peak velocity of about 3 meters per second, a mean gradient of 24 millimeters of mercury, an aortic valve area of actually 0.6 to 0.7 centimeters squared, which would be severe. So by clinical history and exam, those things don't seem to be validated or correlate with our non-invasive findings. Question arises.
Vijay, what should we do next?
Great.
This patient's complicated. There's a lot of comorbid conditions. It's not a very straightforward decision, and we need probably some additional information. So.
Sure. I'm glad you asked. So, given that we have limited utility for further non-invasive findings, and the fact that the patient does have, as I described earlier, COPD, and we would need to further evaluate the patient's intrapulmonary pressure. So we decided to proceed with a right and left heart catheterization as well as an aortic valve study. So the findings of the right and left heart catheterization, this is all combined together. So on the screen, as going from left to right, is the patient's right atrium, right ventricle, pulmonary artery, and then wedge pressure, which shows that the patient has close to normal to moderately or mildly elevated right and left heart filling pressures. The coronaries were not obstructed by findings not shown here today. Next, we proceeded with an aortic valve study where we crossed the aortic valve and noted that the patient had a normal cardiac output and cardiac index, but again had what we would consider a moderate gradient, not severe.
Nicole, would you mind commenting on the different variants of AS and how do we distinguish those?
Okay, so, sure you can hear me. So it actually is recognized that there are 3 different categories of severe AS, which most commonly, probably close to 65% of our patients are actually going to fall into the category of the normal ejection fraction or the normal flow and high gradient, so those who have a gradient more than 40 millimeters of mercury across the aortic valve and a peak velocity more than 4. And that's categorized on the new valvular heart disease guidelines, which was just published last year to be classified as stage D1. Stage D2 is actually those patients who have low ejection fraction and as a result of low flow, most of the time on the basis of impaired systolic function, they have a low gradient. And then finally, as appears to be our case, is the class D3. This patient population actually has a normal ejection fraction with low volume flow rate, which is on the basis of a low stroke volume, and on that basis has a low gradient across that aortic valve. And this term has been termed, or this category has been termed paradoxical low flow, low gradient aortic stenosis.
Samia, how do we distinguish between the low flow low EF and the low flow normal EF? Is there anything we can do to help?
So definitely you could use dobutamine challenge. You could use a gladly. You could use a dobutamine infusion challenge, basically, and also differentiate between pseudostenosis as well as true aortic stenosis. So in pseudostenosis, it's basically there's not enough blood to open the valve, and with the infusion of dobutamine, you won't see an increase in the transvalvular gradient. But you will see an increase in the calculated aortic valve area, whereas in true stenosis, what you'll end up seeing is you will see an increase in the transvalvular gradient, and the calculated valve area will remain fixed. So that would be a useful method, even though it wasn't done in this case.
Swade, would you mind commenting on prognosis? Are these the same or different for each of these groups?
Sure. So So in general, if you have severe symptomatic aortic stenosis with high gradient, you have a poor prognosis. Now how, Nicole just talked about prognosis factors in these categories differ slightly. So if you look at the graph on the left, normally you have normal flow, height gradient AS. That's kind of the traditional AS that most people think about severe AS. It's been shown that for decades we've known that once you develop symptoms when you have this classification, classic AS, that your prognosis is very poor. So life expectancy is usually less than 5 years in these patients. And the only thing that seems to improve it is if you give them an aortic valve replacement. Now, that was category D1. If you look at category D2, which is the graph on the right, again, if you have severe AS, your prognosis is poor. But, and then Soumya mentioned doing a dobutamine echo for these patients. It's been shown, one other piece of information you gain from doing a dobutamine echo is to measure, to see if they have cardiac reserve or contractile reserve. Basically, contractile reserve is when you give them dobutamine, if their stroke volume is going to increase by at least 20%. If it does increase, they say those that have don't have contractile reserve, and it's described as group 2 in that graph. So you can see, compared to people who have contractile reserve, patients who don't have contractile reserve in both the surgical and medical arms, respectively, do worse, again, compared to people who have contractile reserve. So, but in addition, even though these patients without contractile reserve have poorer prognosis, you can tell from the graph that compared to medical therapy, they still do better. So just the fact that they don't have contractile reserve shouldn't isn't a indication for them to get AVR. You should they just compare to people who don't have contractile reserve. It appears to be a little bit more poor. And then next slide.
Yeah. Well, I mean that's great, Shui, but you really covered 2 out of the 3. And so Diane, our patient actually forms in that low flow normally yet. So what do you think for our patient we should be doing here?
Well, this patient population obviously is very challenging to manage. I say that because, one thing is, it's not very uncommon to see this kind of patient. You have low gradient and very low wall area, and also function preserved. So we call it paradoxical severe AS. So, and also not only that, the other thing is it really interrogated all those shortfalls of physically defined severe AS. Based on Bohr equation, to generate a 40 millimeter mercury gradient, which is the definition of severe AS, you need a wall area of 0.81 centimeter square. But we define severe AS as 40 millimeter mercury and less than 1 centimeter. And together with echocardiogram indications such as, we tend to underestimate the OEOP and, the PW tends to underestimate the flow. So on top of that, data in this patient population doesn't really help too much. I know this trial, which was done roughly 2 years ago, has a lot of questions and controversies generated from this. So a lot of people ask, this patient population obviously much more older. In women, they have a lot of hypertension, a lot of comorbidities, just like the case here. Even though this data here, it shows that, for the surgical AVR, they do better. This patient population, if you don't replace the valve, actually they're worse in terms of comparing to not only high gradient AS, but also moderate AS. So, there's many questions regarding this trial, and there's other trials supporting that, the paradoxical AS actually is just moderate AS. So all of them together make it very difficult to how to proceed from here. So in real life, I think when we have this kind of data, I will go back and I will make sure the water is not underestimated. And the most important point for me, I think what I'm concerned is I want to make sure this patient population probably has a mosaic kind of patient population, subpatient population. Some of them though have really true AS. So you really true severe AS. You really want to make sure you have those, you have to differentiate those kinds of patients. I think I really challenge you to really think other imaging modalities. I think you know, just a simple ejection fraction in this part of the population is not does not have the high resolution to differentiate whether this kind of patient has normal function or not, and consider string as longitudinal string is probably much sensitive with detecting myocardial dysfunction in this patient population. So the bottom line is to try to find the true severe AF so they can be benefit from it. And think why this patient has, this kind of patient has low flow, you know, hypertension, high afterload. That's probably one of the reasons. So I think I really, a lot more study to be done in this kind of, in terms of how to go ahead and address, proceed from here. I just think that more subpatient population probably, I mean, this patient population probably has more, you know, mosaic kind of picture. Not only severe, true severe, but also some other things.
All right, thank you, Diane. So in summary, the high gradient, high flow, normal EF is fairly straightforward. It's these low flow, low gradient cases that are a little more problematic. For the low ES, we have the B2B challenge as a tool that we can use to identify the truly significant AS. But the normal ES are still an important patient population, and in fact, it's a 2A indication to go ahead and send those patients for surgical revascularization. So I want to thank the panel and Vijay for this case preparation. And next we'll have Houman Khalili.
Hello, my name is Houman Khalili. I'm one of the Interventional Cardiology Fellows. So, no disclosures. So, a 56-year-old male with a past medical history of diabetes, type 2, on insulin therapy, hypertension, hyperlipidemia, who comes in with complaints of worsening shortness of breath and on exertion for the past 3 months. Vital signs are relatively unremarkable, and he is on appropriate medications, including a beta blocker and long-acting nitrate. His transthoracic echocardiogram, not shown here, was essentially normal with preserved ejection fraction. He underwent a myocardial perfusion study because of his complaints of shortness of breath due to concern for ischemia, which showed a large reversible, moderately severe anterior and lateral perfusion defect. So based on these findings, he undergoes a coronary angiography. So the coronary angiogram, essentially this view is a cranial view showing severe stenosis, essentially the LAD. LAD is pretty much CTO, chronic total occlusion. He has a severe stenosis in his obtuse marginal, and finally the RCA has almost subtotal occlusion. So he has severe 3-vessel coronary artery disease. So the question is, what's the next step?
So the oculo reflex has been activated, and the interventionalists are offering their services. But really, the question is CABG versus PCI the best? You know, which one of those options would be best? And Shui, would you mind commenting on? Is there anything from the data that we've collected so far that can help us in that?
So traditionally, most of these patients were referred for CABG. Over the last 10, 15 years, as PCI techniques have improved, more interventionalists have gone after this. And initially, most people just use their clinical judgment to see which patients with multi-vessel disease should undergo CABG, which patients should undergo PCI. Meaning that most patients with PA undergo PCI. But over the last 6, 7 years, we more and more people have started to use the syntax score to stratify these patients. So the syntax score was derived from the syntax study, which compared CABG versus PCI, multivessel coronary disease, or left main. And basically what the syntax score does is it uses the number of lesions and different factors that are associated with the complexity of angiographic complexity of disease. And you obtain a total score. And from that total score, you're able to stratify patients into different groups. So low risk group, medium risk group, and a high risk group. The low risk group has been shown that, at least when you're looking at hard cardiovascular outcomes, the CABG and PCI seem to be very similar. Whereas the moderate and the high risk group, CABG seems to be better. So as far as hard cardiac outcomes, the low risk group, the two arms seem to do better, but if you look at revascularization, the PCI arm does a little bit worse than CABG. So based on the syntax score, you are able to risk stratify this, and because you have outcomes up to 5 years, this becomes a very attractive tool to use.
Okay, so Houman, what is the syntax score for this patient?
So we calculated the syntax score for this patient, and it was 18, as a matter of fact. And so it fell in the low category that Dr. Abdullah talked about, low risk category. We also calculated the syntax 2 clinical score, which comments on the mortality, 40 mortality with bypass surgery with PCI, and they were quite similar. So this would be next.
Okay, so you're telling me that either PCI or CABG would be appropriate for this patient, but is that really what should we be thinking, or should we be thinking about other options for this patient? Sonia?
Well, I think in with respect to our interventional colleagues, I do think that it would be very reasonable in a stable patient with a normal EF to put him on optimal medical therapy, which he isn't on right now. And I think that would be, what we know from the CARDS trial, like the site says, that since there's no difference in outcome, that would be a really reasonable place to start.
So it looks like from a variety of parameters that this would be a very reasonable strategy.
Yes.
Diane, what about the diabetics? I mean, we've heard in some of these earlier talks how diabetics have an incremental increase, for example, in risk. Is there anything different about them?
Yes, absolutely. So basically, diabetes and vascular biology, certainly there's, diabetic patients, their vascular biology is so different than the non-diabetic. So we know from the VERA-2B trial, this trial was published in 2019, more than 5 years ago now. Although this trial is sort of like compared revascularization versus medical treatment, and it's sort of a negative trial. But in this stratum of CABG, in diabetic patients with stable CAD, actually compared to medical therapy, those patients do much better. So I think the bottom line is complete revascularization in diabetic patients. And also, they didn't compare in this trial the PCI or CABG, which is better. But I think in Freedom trial, which the long outcome paper was published last year, they started to see some separation, between CABG and PCI, although there's no significant.
So that brings Nicole. Is that really true?
She just took the words out of my mouth. So the Freedom trial was randomized trial, which really begged to answer the question once again, which revascularization strategy is going to be optimal in our diabetic patients with multivessel disease. And its results were similar to previously published studies that, in fact, CABG actually is a superior revascularization strategy compared to PCI in diabetic patients with multivessel disease with lower primary outcome, which looked at all-cause mortality as well as a reduction in non-fatal MIs. So probably the right answer, and this was actually seen across all different strata of syntax scores too, by the way.
Right. So I think in conclusion, medical therapy remains a cornerstone for all types of patients. But knowing the coronary anatomy can decide between treatment options in certain subgroups. And certainly for high-risk patients and diabetics with multivessel disease, CABG would be a preferred option over PCI, even at least at this point in time. Okay. I want to thank Houman Khalili for his preparation of this case. And next and last of the case, we'll have Ryan Massard come on up. Thank you.
Good afternoon. Dr. Banerjee and Dr. Balakis asked me to present a case. I was very excited about this opportunity, and I asked what the topic was, and they said advanced cardiac imaging. I was like, as a future interventional cardiologist, I'm like, okay, IVUS, OCT, choose a case with cardiac MRI. So I chose a case that interesting case, and I think just kind of highlights the topic of appropriateness and what cardiac MRI has to offer in this scenario. So I have nothing to disclose. The case is a 27-year-old gentleman who I saw a few months ago. He presented to the ED with a history of syncope and mitral regurgitation, and he had another syncopal episode while walking up the stairs to his apartment. He reports that over the last few months he's had over 10 of these episodes, and they're really true syncopal events with severe bruising and lacerations. He's also having daily exertional dyspnea, chest tightness, lightheadedness, denies palpitations, orthopnea, or edema. Other really relevant history, he said he had his first syncopal episode about 2 years ago in Egypt, had an echo, and he reports that it had some mitral regurgitation and a narrowing of another valve. And that was really all about the history we got. Family history, mother and father, he did say had some cardiac issues, nothing significant, major hospitalizations. He wasn't able to pinpoint that, both alive and well, and notably no family history of sudden cardiac death or syncope. On exam, his vitals were relatively unremarkable, heart rate of 92. He's a little bit overweight, short guy. No major craniofacial abnormalities on general exam. Was relatively benign. His cardiac exam did have a little bit of a hyperdynamic LV on palpation, and he had about a 3 out of 6 early to mid peaking systolic murmur, best heard over the left sternal border. Increases with this Valsalva. He mentioned he had some MR, but you heard that mid-peaking murmur at the apex, and he also had a little bit of a faint holosystolic murmur. Here's his EKG. Really, not too impressive when you look at it, but definitely abnormal, especially for someone of his age. You see signs of LVH. He's got normal sinus rhythm. No changes in his PR interval, but not overwhelmingly LVH as in certain syndromes can be. His chest X-ray PA film, pretty unremarkable film.
Okay, that's great, but this is a cardiology conference, and we're talking about imaging, so can you give us some imaging data on this?
Sure. So starting out with some echo images, this is what we call a parasternal long axis. I'll see if I can highlight with the mouse. This is LV, left atrium, this is the mitral valve, aortic valve, and right ventricle here. And what you see here is that he has some LVH, and particularly the septal is a little asymmetric LVH. And I don't know if you can tell or not, but he has something called systolic anterior motion, which you see of the anterior mitral leaflet comes forward and creates this LV outflow tract gradient. When you add color Doppler, you can see that right there in his LV outflow tract, as well as he does have some mitral regurgitation, as mentioned before. This is a apical 4-chamber view. As you see, he does have the thickening of his septum and mitral regurgitation, or at least about moderate. He had no holosystolic reversal in his pulmonary veins. And then we obtained LV outflow tract gradients. At rest, his gradient was in the mid-20s. This is with Valsalva, not under exercise, but he did have a peak gradient of 51 millimeters of mercury. So to kind of summarize his major echo findings, so asymmetric left ventricular hypertrophy, his septum measured 1.6 centimeters on the peristernal long axis. He did have a systolic anterior motion, what we call a SAM, and he did have a significant LV outflow tract with moderate MR and left atrial enlargement.
Thank you, Ryan. Okay, so it looks like this patient has considerable cardiac hypertrophy. And Diane, would you mind commenting on what the morphologic criteria involved and explain that to the audience here?
Absolutely. So the cardiomyopathy is basically a septal, thickness of more than 15. But this disease we have come to know this disease for so much better now. So actually, the hypertrophic cardiomyopathy should be heterogeneous cardiomyopathy. There's so many different varieties. That's what I'm going to say. And so not only the septal, asymmetrical hypertrophy of the septal, there are different varieties of hypertrophic cardiomyopathy, such as apical cardiomyopathies and reverse curvature of the septum. Even those, sigmoid hypertrophies, some of those patients also carries, the mutation gene. So that being said, I think when you see an echo like this, you should really keep in mind that other problems, such as like fibrous disease, they can have hypertrophy, and also some patients who has the mutation, but their hypertrophy is not as severe. They're less than 15. Some of the patients who have mutation doesn't even have, hypertrophy. So just keep those in mind. Of course, as I go, not only the wall thickness, you want to diagnose whether there is, dynamic outflow obstruction. The significant gradient is continuous gradient, which is peak to peak, more than 30. At rest or with proactive mirrors, and the very severe obstruction, which is more than 50, are indications for surgical treatment and also for alcohol cytoablation. And that's the second thing. The third thing is to kind of like a disease progression monitor, risk stratification. The patient has a family history, and starting from like adolescence and age of 12 to 13, they're supposed to get like every year, 1 year and a half, supposed to have echocardiogram until they reach adulthood, which will be 5 years. And the number 4 indication for echo is very key 20-esophageal echocardiogram is intra operation and operation or intra-procedural, evaluations.
Right.
So there are multiple indications for echo.
Thank you, Diane. So this is great. We have a patient who is symptomatic who came to us and meets the criteria of HCM. But oftentimes, what will happen is we might get a call or a referral. In cardiology clinic, we might see a patient who's referred from the echo lab because of an incidental finding on echo. Nicole, is there anything in those kind of patients that might be helpful to try to determine what we should do?
Sure. So, echoes are great because it's a very common modality to be able to pick up a lot of these incidental findings. Whenever we need more information, perhaps about whether or not these patients are at increased risk for bad things to happen, there is the role now to have these people imaged with cardiac MRIs. So cardiac MRIs have somewhat greater advantages in that really you get a high spatial resolution. You do get better visualization to really ascertain some of these measurements that echo may be less accurate in terms of septal thickness, say for instance. You can get more definitive measurements based on your MRI. And finally, you can use gadolinium to detect delayed enhancement.
And in fact, we have some guidelines now from the ACC and AHA for how to use this tool in ACM. Would you mind commenting on those?
Sure. So, class 1 indication, first of all, anytime there's any diagnostic uncertainty based on the echo, absolutely all these patients need actual cardiac MRIs. Also, as a class 2A indication, really to help determine whether or not surgery or what type of surgery would, whether or not surgery is going to be a beneficial treatment strategy to relieve that obstruction. If the echo is inconclusive once again, and then finally, it now has an indication of class 2B to use cardiac MR to further risk stratify our risk of sudden cardiac death, looking at delayed enhancement.
Thank you. So I know Manos gets all excited about the imaging of the coronary arteries, but until it achieves the level of the cardiac MRI, which Wade I'd like to comment on this patient, this is really remarkable imaging. Would you mind commenting on the findings here?
Sure. So, often echo images here were very nice, but often because of windows or because of bad COPD or other reasons, you may not get good echo images. So, MRI can, as Nicole was saying, it can be used for both diagnostic and prognostic purposes. Here we're looking at Cine. Again, as Nicole was mentioning, you see the intrinsic contrast between the blood and the myocardium, and you can also see the RV here. So MRI, in cases where the diagnosis of HOCM isn't clear, and because of improved spatial resolution, it can be a big help. But here you can see the septum is hypertrophy compared to the lateral wall. Again, this is a 4-chamber Cine. And then these are big gadolinium enhancement images. So basically, we use these images to look for fibrosis. Gadolinium is an extracellular agent, so it'll localize where in the extracellular, where there is more extracellular space. So in viable myocardium or where there isn't much fibrosis, there's gadolinium will accumulate there. But if you inject gadolinium and wait 10-15 minutes, it'll start to go to areas where fibrosis is. In HOCM patients, often they'll have areas of patchy fibrosis. And especially in HOCM patients, you'll have fibrosis in the RV insertion points, and where the hypertrophy is worse, is the most significant. So here, you can see this 4-chamber view. You can see the mid-wall, and then you see a stripe of gadolinium in the mid-wall. So gadolinium, so fibrosis will be represented by this hyperintense signal in the mid-wall of the septum of the left ventricle.
Okay, Sonia, would you mind commenting on how we approach these patients in terms of managing at least the symptomatic patients?
Sure, definitely. In this young man you have here who's medication naive and he's having really significant symptoms of passing out with injury. First-line treatment would certainly be to initiate medical therapy, predominantly with a beta blocker usually. You can also use verapamil or pyramid for some reason if there's any kind of intolerance. And a really important part is identifying their risk for sudden cardiac death if they've had any kind of incidence of ventricular arrhythmias. In this case, he has unexplained syncope if they have a family member with sudden cardiac death, or if they have a Holter with non-sustained VT, as well as LV thickness of greater than 30 millimeters, then he would certainly want to be very proactive about placing an ICD. And oftentimes, treatment options are very center dependent, and there are many established centers now which have certain preferences. And ultimately, should they need further management, you could consider surgical myomectomy or alcohol supplementation in these patients. But in this particular patient, I think initial therapy with a beta blocker and an ICD would be the most appropriate.
Ryan, you want to comment on what actually is done for these patients?
Sure. I thought all your comments were quite insightful, and that's what we did. We started this gentleman on 25 metoprolol, see if he tolerated it, and went up relatively quickly over a span of 2 months. He got up to 300 of toprol XL, and no longer was having syncopal episodes. Still had some residual symptoms, so then we added disopyramide, titrated that up following, making sure he wasn't having QT prolongation with his EKG. The MRI, I think, was helpful. His wall thickness was measured a little bit more than the echo. He had about 2.8 centimeter wall thickness, and the risk stratification guidelines say over 30 millimeters. His age, his young age, and then he did have significant myocardial fibrosis, so an ICD was implanted on him, and we'll continue to follow him.
So, in conclusion, cardiac MRI can be helpful. It can be helpful for both the diagnosis, for treatment decisions and prognosis. And particularly for asymptomatic patients, I think it would be important to consider that as additional imaging modality besides standard transthoracic echo. Medical therapy is an appropriate initial treatment, but for those patients, and certainly an ICD would be indicated for high-risk patients, but for those patients that are medically refractory, then invasive septal reduction therapy can be considered. And it's usually a centered dependent choice on whether it be alcohol ablation or surgical resection. And I want to thank again Ryan Master for that presentation. Lest she thinks she got out of this unscathed, next year we'll be welcoming up Kimberly Taylor Clark, our newest non-invasive member to this panel. But last, I'd like to, and thank you for the panel for all your contributions.